Hello, everybody. This is Chitra Madiwale, and I bring you greetings from Hinduja Hospital, Mumbai, India, where I work in the Department of Histopathology and Cytology. The topic today is my approach to the kidney biopsy. The indication for kidney biopsy is a medical renal disease, and these diseases can be classified as glomerular, tubular interstitial, and vascular. The kidney has limited patterns of response to injury, which means that one disease can have multiple patterns, and similarly, several diseases can have the same pattern of injury. Traditionally, we as histopathologists are accustomed to recognize patterns. We are comfortable with recognizing patterns, but clinicians don't treat patterns. They treat the disease. They need to know what is the underlying pathology, what is the underlying cause, so that they can address it. Therefore, in order to get a meaningful diagnosis in the kidney biopsy interpretation, one needs to be able to recognize the pattern and integrate the findings with the clinical scenario and results of other tests. This gives a meaningful diagnosis, which gives a sense of direction to the clinician regarding the management. What are the tools that are available to us in the interpretation of the kidney biopsy? Light microscopy, and we use special stains. The routinely used ones are PAS, Masson trichrome, silver methenamine, others as may be needed. The sections should be cut at 3 microns, and multiple levels need to be studied. Each of these levels should be studied carefully. Since many of the glomerular diseases are immunologically mediated, immunofluorescence is an important tool in the workup of renal biopsies. And next is electron microscopy. Apart from these three, which are well-known tools for the workup of kidney biopsies, the others available are immunohistochemistry, immunofluorescence on paraffin sections, mass spectrometry, and genetic tests. So the outline of this talk is we shall deal with common glomerular diseases, their patterns, and key aspects, some key aspects of these diseases. And then we move on to tubular interstitial and vascular diseases, and we shall really not have much time to do these. We shall flip through a series of images. Only native non-transplant renal biopsies will be dealt with, as the transplant renal biopsies are a different scenario altogether and require altogether different session. So before we start, we need to begin with the appearance of the normal glomerulus, and this is what it looks like. This is the PA stain on the on the kidney biopsy, and you can see how beautifully it highlights the Bowman's capsule, the capillary walls of the glomerulus, the mesangial matrix, and the tubular basement membranes. Now let's go on to the normal landmarks. This is the glomerular capillary tuft, which is lodged within the Bowman's capsule. The capillaries are supported by the mesangial matrix, which you can see here, the substance between the capillaries, and embedded within this are the nuclei of the mesangial cells. The capillaries normally have patent lumens, and they are lined on their inner aspect by the endothelial cells. Look at the nucleus of the endothelial cell here. On the outer aspect, the glomerular capillaries are lined by the visceral epithelial cells or the podocytes, and here we find the nuclei of the podocytes. The Bowman's capsule is lined on its inner aspect by the parietal epithelial cells. This is the hilum of the glomerulus, at which portion the afferent arteriole enters. This is part of the afferent arteriole. You can see the lumen here. And what are the deviations that can occur from normal? Well, you can get thickening of the capillary walls. And in order to evaluate the appearance of the glomerular capillary walls, one needs to study the peripheral capillary loops, where they are not bound down by the mesangial matrix. So under normal situations, the glomerular capillary walls are 1/3 the thickness of the Bowman's capsule or equal to the tubular basement membrane in thickness. If they are thickened, the glomerulus has a rigid and stiff appearance. The glomerulus normally has this degree of cellularity in a 3-micron section. You can have increased cellularity or glomerular hypercellularity due to an increase in the number of mesangial cells, or there may be an increase in the number of cells within the glomerular capillaries. This may be because of severe mesangial proliferation, which impinges on the capillary lumens, or there may also be leukocytes, neutrophils, or monocytes infiltrating the glomerular tufts. So this type of hypercellularity involving the tuft is known as endocapillary hypercellularity, which may be due to mesangial hypercellularity or due to proliferation within the lumen of the capillaries. The other type of hypercellularity is the extracapillary hypercellularity, which is seen within the urinary space, the Bowman space, which is being outlined here, and is seen in the form of crescents. The other changes that can be present include a situation where you get mesangial hypercellularity as well as glomerular capillary wall thickening, giving rise to what is known as the MPGN pattern. Yet other alterations include necrosis of the glomerular tuft, thrombi in the glomerular capillaries, endothelial swelling, leukocytic infiltrates, deposits of various types, and sclerosis, which may be segmental or it may be global. At this point, we need to understand the terminologies focal versus diffuse. Focal refers to some glomeruli being involved and others being normal, whereas diffuse means all the glomeruli are involved. When we are talking of lupus nephritis, diffuse refers to involvement of more than 50% of the glomeruli. The term segmental is used when only a portion of the glomerular tuft is involved, whereas the term global is used when the entire glomerular tuft is involved. Keep in mind that even diseased glomeruli may appear normal at light microscopy. So this was about the light microscopic appearance of the normal glomerulus, and we go on to the next, and that is the immunofluorescence. Immunofluorescence is routinely performed using antibodies against the antigens which may be deposited in the glomerulus. And the routinely used antibodies are antibodies against IgG, IgA, IgM, C3, C1q. And here, please do not forget to use kappa and lambda antibodies as well. Otherwise, you are at the risk of missing diagnosis of immunoglobulin, monoclonal immunoglobulin derived diseases altogether. These antibodies are tagged fluorescein isothiocyanate tagged antibodies, so they light up the antigens wherever they are present in the glomerulus. One needs to evaluate the fluorescence microscopy by looking at the distribution of the deposits. Where are they present in the glomerulus? Are they in the mesangium? Are they along the capillary walls? Are they present in the Bowman's capsule? Is there staining along the tubular basement membranes? Is there staining in the tubular casts? All these have to be evaluated. Apart from their distribution, the second aspect that one needs to evaluate on immunofluorescence is the intensity of staining. And this is graded in a semi-quantitative manner from 0 to 3+. The third aspect is the pattern of staining. Is it granular? Granular pattern is usually seen in immune complex diseases. Is it linear? Is it blotchy? Is it a broken linear pattern, etc.? Here we have a linear pattern of staining in this figure. This is a linear pattern of staining along the capillary walls. And this antibody is IgG. And this is intense staining along the capillary walls. This was taken from a case with anti-GBM nephritis. At the electron microscopy level, we have to first get our bearings. And this is something that I used to find difficult until somebody told me that you first look for the podocyte. And indeed, when you first look at the podocyte, then you can immediately get your orientation to the glomerulus. And that's because the podocyte has these food processes emanating from the cytoplasm of the cell, and these rest on the glomerular basement membrane on its outer aspect. So we are well aware of the fact that the glomerulus is a sieve which filters the blood and prepares a filtrate, a glomerular ultrafiltrate, which goes into the Bowman's space and is eventually converted through its passage, from its passage through the tubules into the urine. The glomerulus acts as a sieve and it keeps important substances out of the urine because it has a charge selective and a slice selective function. And because of the charge selective function, the anionic molecules are repelled because the glomerular basement membrane has a net anionic charge. And similarly, molecules of the size of albumin and higher are automatically not allowed to enter the urine. This sieve-like function of the glomerulus occurs on account of the fenestrated endothelial cells, the glomerular basement membrane. This is the glomerular basement membrane here. This is the nucleus of the endothelial cells. The glomerular basement membrane has the lamina densa, which contains type 4 collagen. And the most important cell, the cell that plays a pivotal role in the filtration function of the glomerulus is this cell, the podocyte. And here is the podocyte. Here are its food processes, and this is the nucleus of the podocyte. This is the largest cell of the glomerulus, and in between its food processes, as you can see here, are the filtration slits, which are covered by the slit diaphragms. And it is the slit diaphragm which plays a very, very critical role in the filtration function of the glomerulus, not allowing substances like albumin to pass into the urine. Also, the intactness of the glomerular basement membrane does not allow RBCs to enter the urine. Anything that damages the basement membrane, anything that interferes with the function of the podocyte will result in loss of these components into the urine and result in disease. So what do we evaluate at electron microscopy? Of course, we evaluate the podocytes and their food processes. We look for the presence of electron-dense deposits and their location, and we study the status of the glomerular basement membrane. Now, having talked of the podocyte, we begin our discussion with the podocytopathies, which are diseases of the podocytes, and knowing that the podocyte plays a critical role in the filtration function of the glomerulus, these podocytopathies will present with nephrotic syndrome. Now, podocyte response to injury can be seen in the form of food process effacement, in which the food processes retract within the cytoplasm of the podocyte. And in severe injury, there can be detachment of these podocytes from the glomerular basement membrane. So the minimal change disease is an example of podocytopathy in which there is injury to the podocyte. The podocytes are stressed, but the injury may not be very severe, and there can be only foot process effacement in minimal change disease. However, if the podocyte injury is much more severe, you have more stress to the podocytes, then you'll get podocyte detachment from the glomerular basement membrane and death of the podocytes. And remember that once the podocytes die, they are not replaced. Each of us has a fixed number of podocytes in our kidneys, and loss of podocytes is one of the important causes of glomerulosclerosis. So if there is podocyte detachment or death, that results in bare areas along the glomerular basement membrane. And these bare areas, the glomerulus tries to repair these areas. The visceral epithelial cell, the parietal epithelial cells that line the inner aspect of the Bowman's capsule come and attach themselves to that particular injured portion of the tuft. So also the mesangium plays a role, and there is sclerosis in that portion, and you end up getting a focal segmental glomerulosclerosis. You can also have podocyte proliferation. Now, actually, podocytes are terminally differentiated cells. They do not really undergo multiplication. But there are certain types of podocyte injuries where this does occur. A low degree of proliferation may occur in diffuse mesangial sclerosis, which results in congenital and infantile nephrotic syndrome, and a very high degree of proliferation occurs in collapsing glomerulopathy, which is known to result in very severe nephrotic syndrome and has a very fulminant course. Now, awareness of all these responses to injury is important because modifying this response may be a promising strategy for reducing podocyte injury. Now, this is a biopsy from a minimal change disease, and the clinical scenario is very typical. It's usually a childhood disease. The patient has nephrotic syndrome. It's usually albumin that is lost in the urine. It's a selective proteinuria. It has a very abrupt onset, and it is typically steroid responsive. Unusual features include deranged renal functions, hypertension, and hematuria. On biopsy, there is no change in the glomeruli at light microscopy. However, very subtle podocyte prominence at light microscopy may be a clue to the underlying disease. Why do these podocytes become prominent? Because they are damaged, they are stressed, and also because they are stressed, there's urine loss, protein loss in the urine. So the podocytes try to grab the urine as it's being, grab the protein as it's being lost in the urine, and they swell up and may become prominent. Typically, in minimal change disease, in the biopsy, you will not find any interstitial fibrosis or tubular atrophy. Minimal change disease may be primary, or it may be secondary to infections, sometimes secondary to malignancy, or even secondary to drugs like non-steroidal anti-inflammatory drugs. On immunofluorescence, it's usually all negative. Sometimes you may get some degree of staining for IgM and some degree of staining for C1q. And the cases that show IgM and C1q staining are the ones which may not be really steroid responsive. There can be an interesting pattern of staining with IgG. You can get a punctate pattern of staining with IgG, as you see over here. And this may then mimic a membranous glomerulonephritis. Now, why does this type of punctate pattern of staining occur? This is because of presence of antibodies to nephrin. And the nephrin is a protein that maintains the slit diaphragm integrity. And remember, the slit diaphragm plays a very critical role. It's the backbone of the filtration process of the glomerulus. And antibodies to nephrin may be found in a subset of minimal change disease, which in that situation becomes an autoimmune process. And in such cases, rituximab may help in the treatment. So this is the punctate pattern of staining which may be seen. It may cause diagnostic confusion, and therefore one needs to be aware of this particular pattern. At electron microscopy, the characteristic feature is diffuse food process effacement. Extensive diffuse food process effacement, as you see here. You can barely see a food process here. The rest is all, they are all effaced. They're all taken up into the cytoplasm. The food processes have merged with the cytoplasm of this very, very swollen podocyte. So this kind of extensive diffuse food process effacement involving more than 75 to 80% of the tuft of the glomerulus that you see on electron microscopy is very characteristic of minimal change disease. Along with the sudden onset of nephrotic syndrome, that is almost like an explosive onset of nephrotic syndrome, these two features are very characteristic. The sudden onset nephrotic syndrome and the extensive diffuse food process effacement. At this stage, it would do well to remember that food process effacement is not a feature that's exclusive only for minimal change disease. It can occur in any form of podocyte injury and any kind of proteinuric state. But the extensive food process effacement is a feature in conjunction with the rest of the clinical scenario and the rest of the biopsy finding that is very characteristic of minimal change disease. Now, is minimal change disease the only one which can have no changes at light microscopy? Indeed not. There are several others. Early amyloid, thin basement membrane disease, Alport, early diabetes, and early membranous can all have a minimal change disease-like appearance at light microscopy. How do you resolve them? Electron microscopy helps in detection of very early amyloid. Thin basement will have thin basement, and Alport's has a characteristic pattern. Sometimes IgA nephropathy can have a MCNS-like appearance. Sometimes in SLE, though we are well aware, it usually has a full house pattern on immunofluorescence and it shows changes on light microscopy. Some cases of SLE may have only food process effacement and no staining on immunofluorescence. This is known as lupus podocytopathy. And the way to diagnose these situations is again by immunofluorescence for IgA nephropathy. For lupus podocytopathy, the patient should be a diagnosed case of lupus nephritis. It should have satisfied the ACR criteria for diagnosis of lupus. And then if you do not find any staining on immunofluorescence and you find extensive diffuse food process effacement on electron microscopy, then you're probably dealing with a lupus podocytopathy. Unsampled FSGS may be misdiagnosed as minimal change lesion. There are certain red flags, however, that help you. Check the number of glomeruli to see if there is any sampling error. If the number of glomeruli is less than 20, it is possible that there has been a sampling error. If there are more than 20, it's unlikely that you have missed an FSGS. FSGS also tends to affect the juxtamedullary cortex. And if that portion of the cortex has been sampled, it's quite unlikely that you have missed an FSGS. If there is interstitial fibrosis and tubular atrophy, then you have to be on the alert because this is not a feature of minimal change. If you see this, you have to worry whether there is FSGS in some other portion of the biopsy, which in some other area which has not been sampled. If glomerulosclerosis and arteriolosclerosis are present, this again is unusual for a minimal change lesion. C1q nephropathy can also show heterogeneous histology. It can resemble minimal change disease, FSGS, or a proliferative glomerulonephritis. Immunofluorescence with at least 2+ staining for C1q will help make the diagnosis. So if minimal change disease has such a characteristic appearance, where is the need to biopsy it? Well, you should perform a biopsy at the two extremes of age. Nephrotic syndrome at less than 1 year of age, because these may have a genetic basis, and in adult onset nephrotic syndrome, because it may not be minimal change. You don't want to be missing some other disease like a membranous or amyloid or something else. Any cases of minimal change that are steroid dependent or steroid resistant or frequently relapsing should be biopsied. In minimal change disease, sometimes the clinicians want to give steroid sparing treatment. They wish to avoid the ill effects of steroids. And one of the treatments that they may offer is the calcineurin inhibitors. And these are known to be nephrotoxic. And therefore, they like to do a baseline biopsy before starting this therapy to see what the baseline kidney biopsy looked like, so that if there is any alteration in renal function at a later date, then they perform a biopsy later, then they have a baseline biopsy to compare it with. Remember that minimal change disease is not always harmless. There may be acute kidney injury because of volume depletion. The patients are severely hypoproteinemic, severe anasarca, and therefore decreased intravascular volume, and this may result in acute kidney injury. There may be thrombotic episodes because of loss of antithrombin 3 in the urine. They may be more prone to infection because of protein loss in the urine. Pediatric onset can persist into adulthood, and some cases of minimal change disease may evolve into FSGS. So here we have a diagram. You know, they do overlap. This is minimal change disease. Their spheres do overlap. This is minimal change. This is FSGS. And the case of minimal change which shows some degree of IgM, the case of minimal change that shows some degree of mesangial proliferation may be more at a risk for developing FSGS. Their podocytes, the podocyte stress levels may increase over a period of time, and they may eventually develop FSGS. So whether these are two separate entities or a continuum of the same spectrum is an interesting thought. Now this is focal segmental glomerulosclerosis. You can see the solidification of the glomerular tuft. Over here, it is involving only a part of the tuft, only a segment of the tuft. The rest of the tuft is normal. And also there's no increase in the cellularity of the tuft. Segmental sclerosis is usually also silver positive. And often with segmental sclerosis, you do see adhesions to the Bowman's capsule. Because remember, we discussed that with segmental sclerosis, focal segmental sclerosis, the degree of podocyte damage is much more. The podocytes detach. They may die, leaving bare areas of the glomerular basement membrane. And then the parietal epithelial cells try to come and repair the damage. The mesangial cells come and try to repair the damage. And this results in sclerosis. The FSGS also results in severe nephrotic syndrome, but the degree of damage to the glomerular basement membrane is more severe. The patients may also have microscopic hematuria. They may be hypertension. Immunofluorescence shows in sclerotic areas, there's a tendency to non-specific trapping of some immunoglobulins, and the immunoglobulins that are known to show this non-specific trapping is IgM. It can get trapped in areas of sclerosis. Similarly, C3 can also get trapped in areas of sclerosis. On electron microscopy, you get a variable degree of foot process effacement. Now, this is also FSGS, and this is the segment, this is the collapsing variant of FSGS. Here, the degree of damage to the podocytes is very severe. And in fact, this is one of the situations where the podocytes paradoxically not only, increase in size, they not only undergo hypertrophy because of damage, they not only swell, but they also multiply, and they form this cap-like, crescent cap-like structure over the outer aspect of the glomerular tuft. And this is the collapsing variant. The reason why it's called collapsing is because there is, severe retraction of the capillary walls. They come together and you cannot see the lumens, and there are small areas of sclerosis. So this is a very fulminant form of focal segmental glomerulosclerosis. And here is another example where you can see the very markedly hyperplastic and hypertrophic damaged podocyte with collapse and shrinkage of the glomerular tuft. Here is another example of a 30-year-old male who had hematuria following upper respiratory infections, severe proteinuria, and on immunofluorescence, there was 3+ staining in the mesangium for IgA. And what do we find here? This is sclerosis, solidification of a portion of the capillary tuft. Almost half the tuft has got sclerosed. And this is a case of IgA with secondary FSGS. Segmental sclerosis is something that we need to worry about whenever it occurs, because it begins off as a segmental process, but eventually it can be global and it can involve more glomeruli. It may not remain focal. So that then, can result in a chronic renal disease. FSGS is a pattern of injury. It's a pattern that we can recognize at light microscopy. And the causes, it can be primary due to an inherent defect in the podocyte, or it can be secondary due to, for example, you have soluble plasma factors, the SUPAR antibodies, which may be circulating, and they are known to result in FSGS. And we have to be aware of this because patients with these kind of soluble factors, the FSGS can recur really rapidly after transplant, and you might want to remove these antibodies by plasmapheresis. FSGS can also occur if the glomeruli are working more, they are filtering more, they are more stressed, and this can occur if there are developmentally less glomeruli, in the situation of congenital renal abnormalities, in obesity, and patients on anabolic steroids. All of these can give rise to glomerular hyperfiltration, overworked glomeruli, and FSGS. FSGS may actually represent areas of glomerular scarring, and this may be the sequelae of several types of diseases like hypertension, diabetes, IgA nephropathy, and nephropathy and reflux nephropathy, to name only a few examples. And FSGS can be the result of collapsing glomerulopathy, which is best known in HIV-associated glomerulopathy. It can be due to APOL1 genes. It can be due to parvovirus, drugs like bisphosphonates, thrombotic microangiopathy, and autoimmune. All of these can give rise to collapsing glomerulopathy. And FSGS can importantly be due to a genetic effect. Now, coming to the role of genes and their relationship to nephrotic syndrome and FSGS. Is it only that they are involved in childhood nephrotic syndrome? Well, even adults can have abnormal genes. Adult FSGS can also have these genetic abnormalities. Now, let's look at the names of a few genes which are involved in development of FSGS. There are several examples. Prominent among them are APOL1 gene, the INF2, the COL4A4, and the COL4A3 genes. COL4A4 is associated with Alport syndrome. NPHS1 and NPHS2 genes, which are due to defect in the podocin and nephrin components, which are both components of the slit diaphragm. And how do we test for these genetic defects? We have Sanger sequencing, next-gen sequencing, genome and exome sequencing, and appropriate panels can be used. And who should be tested for this? So genetic testing should be performed in steroid-resistant nephrotic syndrome, because if genetic abnormalities are found, then it impacts the treatment decisions, diagnosis, prognosis, and even the situation of genetic and even the role of genetic counseling comes into the picture. Now, coming to the what are the implications, or how do you recognize these different types of FSGS? Eye flat microscopy, they have similar findings. There are no definite features to distinguish between permeability factor related FSGS, other secondary FSGS, and genetic FSGS. Electron microscopy, there is food process effacement to variable degree. It is often diffuse in the permeability factor related and variable segmental in the other forms. The treatment implications are different. Permeability factor related FSGS, there is a role of plasmapheresis, and 70% of them may respond to immunosuppressants. For other secondary forms of FSGS, you would like to reduce the intraglomerular blood pressure, reduce the intraglomerular hypertension, reduce the hemodynamic stress within the glomerulus, which is done by the use of RAS inhibitors. For genetic FSGS, they have really a very variable response to immunosuppression and RAS inhibitors. Recurrence after transplant occurs in 70 to 80% of the permeability factor related FSGS, while the secondary forms and the genetic forms do not recur following transplant. And one can't leave the topic of FSGS without talking about the Columbia classification of FSGS. And this is, these are the various types that are shown here. This is the tip variant, the glomerular tip variant, in which a portion of the glomerular tuft pouts into the area where the tubules, the proximal tubule begins. It may not really show sclerosis, but though not very well seen in this picture because I didn't have a better picture, but there may be foam cells present within the affected portion of the tuft, giving it a pale appearance, or there may be hyaline glassy material present there. And this is known as the tip variant of FSGS. The sclerosis is not often prominent. It more often has a more cellular look. And this is possibly thought to have a better prognosis among all the types of FSGS. Then you have the perihilar type of FSGS, which is often the secondary type of FSGS. Collapsing type of FSGS, we have seen that they have extreme swelling and multiplication of the podocytes, severe retraction of the tuft, and subtle degree of the sclerosis, of the sclerosing lesions. This is a very fulminant type of FSGS, often referred to as malignant FSGS. There's yet another variant of FSGS known as the cellular variant, which can be mistaken as a proliferative glomerulonephritis. It is associated with severe proteinuria and increased chances of end-stage renal disease. And you have the NOS, FSGS NOS type, not otherwise specified type, of which 33% may respond to steroids. And here I would just like to end the story of FSGS by showing you this case of HIV-associated nephropathy with severe collapsing FSGS. Note the podocyte proliferation and prominence. Look at the collapsed tuft here. And it's actually a constellation of findings in HIV-associated nephropathy. You have this collapse, you have podocyte prominence, and you have tubular microcysts, because it is thought that the virus actually may even damage the tubular epithelium. So you have tubular microcysts, and these cysts contain large pale staining casts. On electron microscopy, you may have these tubular reticular inclusions within the cytoplasm of the endothelial cells, and these are thought to represent footprints of the virus. Let's take a little break and deal with what are the causes of severe proteinuria. And the causes that should come to mind are HIV-associated nephropathy, FSGS, amyloid, membranous, and monoclonal immunoglobulin deposition disease. These conditions can give rise to very, very severe proteinuria. Let's move on to another pattern of injury with nephrotic syndrome. So here we find that the glomerulus does not show any increase in the number of cells. What it does show, however, is a stiff and rigid appearance due to the significant capillary wall thickening. Look at all these thickened loops over here. They're almost equaling the thickness of the Bowman's capsule. And the tufts have a rigid open appearance. So this is membranous glomerulopathy. And what is this? This is a silver stain of membranous, and you can see these characteristic spikes. Now, are these spikes the deposits of membranous? No, they are not. Deposits of any glomerular disease, the immune deposits, do not stain. They are not silver positive. In fact, they may stain with mason. They may have a pink fusianophilic color with mason, but they are not silver positive. So what do these spikes represent? They are actually, membranous is a very indolent type of disease. The deposits are subepithelial in location, and they just stay there for a long time. And therefore, the basement membrane decides that it has to restructure itself around these deposits. And therefore, it grows in between the deposits and eventually covers them as well. So when it is growing in between the deposits as a form of restructuring itself, that is when you get the formation of these spikes. Membranous generally has an indolent clinical course. The deposits stay there for a long time. Sometimes there may be even self-resolution. And membranous can be primary or it can be secondary. And the three important causes of secondary membranous are SLE, hepatitis B virus, and drugs. Now, on immunofluorescence, membranous will show a fine granular peripheral capillary wall staining. It's got a very striking appearance, finely granular peripheral capillary wall staining with IgG. And on electron microscopy, here are the deposits in the subepithelial location. This is the mesangium, the mesangial cell. This is the glomerular capillary lumen. This is the nucleus of the endothelial cell. This is the basement membrane, and these are the deposits. They are subepithelial in location. This is the big podocyte. The podocyte is always the largest cell in the glomerulus. It extends from one loop to the next and to the next. So these are the deposits, looks like almost like a necklace of pearls. So this is what you see on electron microscopy. Remember, the deposits in very early membranous may be small, may be difficult to pick up, and early membranous may look like minimal change disease. They may even be difficult to pick up on immunofluorescence, and therefore in that situation, it will help to do an electron microscopy. Membranous, like I mentioned earlier, can be primary or it can be secondary. And one of the important causes of secondary membranous is SLE. And you can suspect a secondary membranous if you find that the deposits, instead of being predominantly subepithelial, are also subepithelial and mesangial in location. And the other thing that helps serve as a pointer to secondary membranous, particularly a secondary membranous due to lupus, is that if you find a mixture of deposits with IgG, IgA, C3, and C1q, instead of only IgG, which is you see in only pure membranous, in primary membranous, if you find a mixture of these, then it's a pointer to SLE. Now, is membranous primary or is it secondary? It is important to decide because in secondary, you can treat the possible cause and the membranous, and that may help in resolution of the membranous. So what can we do to decide primary versus secondary? You have serology, HBV, you can have the lupus serology, viral markers. You can have careful clinical history, look for history of drugs, workup for malignancy, careful evaluation of the immunofluorescence and electron microscopy. All these can help decide whether it's primary or secondary. And then you have the antigen workup, which is what is done these days. You will have a variety of antigens, a platter of antigens to help you decide whether this is a primary membranous or a secondary membranous glomerulonephritis. Then it is useful to do this as a single test. It possibly avoids the exhaustive workup that you may need to perform to distinguish between primary and secondary membranous glomerulonephritis. So since between 2009 to 2014, several antigens have been detected to be associated with membranous, and new antigens keep getting added to the list. Among the important ones, PLA2R and THS-D7A are usually positive in most cases of primary membranous, and secondary membranous is usually PLA2R negative. And now, apart from PLA2R, there are so many newer antigens with newer IHC antibodies. For example, exhaustocin 1 and 2 for autoimmune type of membranous, NEL1 for malignancy-associated membranous, SEMA-B3 for pediatric membranous and membranous associated with genetics, and so many others. So membranous is actually summed up in this article. Membranous nephropathy is actually really a different disease with, they are really different diseases with one pattern. And here you have the PLA2R staining by immunohistochemistry. And you have to look for the PLA2R as granular staining where the along the basement membrane. The podocytes should not be positive. So it has to be present along the basement membrane. So this PLA2R is seen along the cytoplasmic, along the base of the podocytes, and this is how it gets picked up on the IHC staining. Now this is another pattern of injury. What you notice here is, look at this glomerulus. It looks as though it has lobules, a lobule here, a lobule here, here. These are like lobules. And this lobular appearance has occurred because there's an increase in the mesangial matrix. Apart from the increase in the mesangial matrix, there is also an increase in the number of mesangial cells. In fact, there is also encroachment on the capillary lumens. There are many of them don't look patent, altogether patent. So there is some mesangial and endocapillary proliferation. There is an increase in the mesangial matrix. And look at the glomerular capillary loops. There is thickening of the glomerular capillary loops. Look at the rigid stiff appearance. So this pattern of injury is the membranoproliferative glomerulonephritis pattern. And the matrix, as you can see, is beautifully highlighted by the PA stain, and the capillary wall thickening is also well highlighted by the PA stain. This type of injury can give rise to nephritic syndrome, nephrotic syndrome, hypertension, hematuria, leukocyturia, and azotemia. Now again, just like FSGS, MPGN is a pattern. It can be a primary MPGN, which is type 1 and type 3, and or it can be, this type of pattern can be seen in dense deposit disease, which formerly used to be classified as MPGN type 2, but now it is part of the family of C3 glomerulopathy. Yet other examples of MPGN are glomerular deposition disease due to presence of monoclonal immunoglobulins, cryoglobulins, immunotactoid, and fibrillary. SLE, hepatitis B, and HCV can all result in glomerular diseases with MPGN pattern. And not to forget, MPGN-like pattern can also be seen in thrombotic microangiopathies and IgA nephropathy. So this is MPGN 1 and 3, how are they different from dense deposit disease? In MPGN 1 and 3, these are immune complex diseases. And in MPGN 1, you usually get subendothelial immune complexes, electron dense deposits. In MPGN type 3, you get subendothelial and subepithelial electron dense deposits. On the other hand, dense deposit disease is actually an autoimmune process. It is due to presence of circulating antibodies such as C3 nephrotic factors, complement factor H, and complement factor B. In C3, in MPGN 1 and 2, there is low C3 in the blood. The levels of C3 in the blood are low, and this depletion is because of activation of the classical pathway of the complement system. Whereas in dense deposit disease, the C3 is broken down by the presence of these autoantibodies, and this breakdown occurs due to the alternate pathway activation. So moderate C3 reduction is seen in MPGN 1 and 3, whereas severe persistent C3, which fails to normalize, is a feature of dense deposit disease. Also, because it's a circulating factor, there is 100% chance of recurrence of dense deposit disease in the renal allograft. So these are some very important differences that we should be aware of. And we have to remember that both of these, all these, the MPGN 1 and 3 and dense deposit disease, both can have an MPGN pattern. On immunofluorescence, in MPGN 1 and 3, you will get C3, but in addition, you will also get presence of immunoglobulins. And here we have IgG present not only in the mesangium, but also along the capillary walls. And coarse staining is present. Now, let's look at this case of an MPGN pattern. This is an 18-year-old male with proteinuria, hematuria, and deranged renal parameters. Definitely, there's an MPGN pattern. And look at the brightly eosinophilic appearance of the glomerular basement membrane. If you were to do a PA stain, it would have a fusinnophilic appearance. And this is a very, very characteristic appearance of MPGN pattern due to dense deposit disease. On immunofluorescence, it shows, I think we have pictures coming up later, but what I would like to show is that, this is the MPGN pattern, bright PA is positive, but you have to confirm the diagnosis, your suspicion, by electron microscopy. This is a net image, and you can see this very dense deposition that is present along the glomerular capillary walls. It's often referred to as a sausage string pattern of unique electron dense material in the GBM, also in the mesangium and in the tubular basement membranes. This material represents the alternate complement pathway material which is laid down in the basement membranes. So dense deposit disease can affect not only the glomerular basement membranes, but also the mesangium, the tubular basement membrane, and in fact, it can be a multi-system disease. It can even involve the eye. So these are features that you have to be aware of. On immunofluorescence, dense deposit disease shows very characteristic ribbon-like staining for C3, and you may see presence of rings in the mesangium. There may be even staining in the tubular basement membrane. This is a text illustration showing the ribbon-like intense staining for C3 with the presence of mesangial rings. You do not get immunoglobulins with dense deposit disease. So it is only C3 that is present. It's important to recognize dense deposit disease because it progresses to end-stage kidney disease in at least 50%. There's 100% chance of recurrence in grafts. And you have to give, a very expensive treatment is used for this, and that is eculizumab, which is one of the most expensive drugs. It is a drug used against the CD5, which is one of the factors, antibodies, which controls the alternate pathway of the complement system. Plasma exchange and recombinant complement factor H may also be considered as therapy for dense deposit disease. Now here again, we have an MPGN pattern. And you will agree that the MPGN pattern is, there's a lobular, in fact, almost a nodular appearance of the glomeruli in the mesangial areas, increased numbers of mesangial cells. How do you comment on increased number of how do you comment on mesangial hypercellularity? In a given area within the mesangium, you should not have more than 3 nuclei. In a 3 micron cut section, you should not have more than 3 nuclei. If there are more than 3 nuclei in a given focus in the mesangium, then this is mesangial hypercellularity. And of course, when you're evaluating the mesangial cellularity, move away from the hilum, because in the hilum, there's always a little more mesangium, little more cells. So always look at the more peripheral portions. So here we agree that there is a nodular lobular appearance, mesangial hypercellularity. There is also capillary wall thickening. The mesangial nodularity is intensely pass positive. So when you see this, there's a straight thought, could this be amyloid? But no, amyloid would not have this kind of hypercellularity, and amyloid is never so intensely pass positive. On silver stain, you can find that this is negative, silver negative. And if you do a immunofluorescence, you find there's no staining for the lambda light chains, there's staining for the kappa light chains. And on electron microscopy, you find the presence of these powdery deposits along the endothelial side of the basement membrane. These fine electron, fine powdery deposits are present. This is the characteristic appearance. Look at these. This is the characteristic appearance of MPGN pattern due to a monoclonal immunoglobulin deposition disease. Now, there are other diseases which can have an MPGN pattern. For example, again, an MPGN pattern here, and electron microscopy showing immunotactoid glomerulonephritis. These immunotactoids have these microtubules which are hollow, which have hollow cores. This is more like a membranous pattern with increase in matrix. And on electron microscopy, you find these fibrils. And these fibrils are not like amyloid fibrils. They are thicker. They're almost 10 to 13 nanometers. And this is a fibrillary glomerulonephritis. Now, while EM has a role and does help us in recognition of these fibrils, now we have the presence of an antibody known as, I'm sorry, I think the D got skipped, but it should be not NA, it should be DNA JB9, which is positive in fibrillary glomerulonephritis. So we don't really need to do EM. If you suspect fibrillary, then you can run this antibody, and if it is positive, then you have your diagnosis as a fibrillary glomerulonephritis. And this is again a MPGN pattern. In fact, here in another glomerulus, these kind of thrombi were seen, almost like, present these kind of large deposits or were present within the glomerulus. And this was a case of cryoglobulinic glomerulonephritis. And on electron microscopy, they have a definite appearance. They are seen as bundles of fibrils and microtubules on electron microscopy. So all of these are MPGN pattern, but all of these are different. But what we need to remember is that some of these, especially immunotactoid and cryoglobulinemic glomerulonephritis types 2 and type 1 and type 2 may be associated with a monoclonal plasma cell disorder. The fibrillary are more often polytypic in nature. They sometimes may be monotypic in nature. So all with MPGN pattern. So this is something we don't want to miss. We never want to miss an immunoglobulin deposition disease because the treatment is different. it is treated as a hematologic malignancy. And therefore, we have to have a high suspicion index to pick up these. And it's not that the patient is always a known diagnosed case of a plasma cell disorder. In fact, the kidney biopsy may be the first indication of the presence of the underlying clonal plasma cell disorder. And the looks and presentation of these immunoglobulin deposition diseases in the renal biopsy can mimic MPGN. They can mimic a nodular diabetic glomerulosclerosis. They can mimic amyloid, which itself can be associated with plasma cell disorders. Membranous, mesangial-proliferative, they can have crescents, they can look like a thrombotic microangiopathy. They can also look like other proliferative glomerulonephritis, such as infection-related glomerulonephritis and C3 glomerulopathy. So this is something that we have to keep at the back of our mind always, because they can have variable appearances. And they can, how do we then, make the decision? The tools available at our disposal are special stains like Congo Red for amyloid. Then if it's silver negative, we start suspecting, could it be amyloid? Could it be monoclonal immunoglobulins? Immunofluorescence with kappa and lambda light chains. You should never miss doing that, because staining of one and absence of the other is very valuable clue to the presence of a monoclonal disorder, immunoglobulin disorder. Electron microscopy helps because each of these has a definite type of EM appearance. And in challenging cases, you can actually characterize the nature of the deposits by doing a mass spectrometry, in which you extract the substance, the deposit from the glomerulus by laser micro dissection, and then subject it to mass spectrometry, and you can characterize it more precisely. Sometimes the immunoglobulin deposits may be masked, and they need paraffin immunofluorescence to expose them. So with that, we move on to this, which is all of you, it's very easy to recognize this type of pale material present within the glomerulus, very light staining. It's almost as though it's flowing within the mesangium. Its presence here, it is present here as a nodule. It can be present along the capillary walls. It is here in subtle in amount. This is faintly pass positive. It's never intensely pass positive. Look at it here, just along the capillary walls. It is silver negative. And of course, this is amyloid, which is Congo red positive with the characteristic apple green birefringence and the typical 7 to 12 nanometer fibrils that you see on electron microscopy. So this is a little more of the same to show you the delicate texture. Here it is seen on the wall of the arteriole in the mesangium. It is pass negative, Congo red positive. Congo red polarization shows apple green birefringence. And on immunofluorescence, it shows lambda light chain staining, which makes this as a AL type of amyloid. Now, amyloid diagnosis of amyloid is not difficult. There's no premium on making a diagnosis. It's easy enough to diagnose. But what we need to do is subtyping of amyloid, and that is the standard of care. And how do we do the subtyping of amyloid? Because the subtyping is important, because the treatment of A amyloid is different from the treatment of AL amyloid. Amyloid with light chains would have to be treated as a plasma cell disorder. So how do you make this difference? How do you make this do you make the distinction? And of course, apart from AL and AA amyloid, there are so many other types of amyloid. You have, the familial types and several others, and each of them has a typical type of signature. So immunofluorescence helps, and we must, of course, do the kappa and lambda light chains in each case of amyloid to look for whether it's AL, whether there's any light chain restriction. But it has its limitation. There may be no difference in the intensity for kappa versus lambda. They may be false negative, there may be non-specific trapping of with AA amyloid for the light chains. Amyloid is a very, very sticky protein, and on fluorescence, it traps a lot of these light chains, and you can get a lot of non-specific staining. So inconclusive immunofluorescence for light chains does not always exclude possibility of AL amyloid. Well, we can use immunohistochemistry, but there is high background staining for AL amyloid. The antigen epitopes may be lost during formalin-fixed paraffin embedding in the formalin-fixed paraffin embedded sections. The antibody sensitivity and specificity differs. Several antibodies may be required for precise typing of the amyloid, and in rare cases, you may have more than one type of amyloid even. It's really not practical for any general surgical pathology lab to have different types of antibodies to detect different types of amyloid. So then what's the answer? You have to refer them to a referral center, like you have the National Amyloidosis Center in the UK. In India, there are some centers which have more antibodies for the amyloid subtyping. And then you have proteomics, in which you do a laser microdissection and mass spectrometry, and you can determine the protein signature of the amyloid. And for this, paraffin blocks can be used and sent to a referral center, which performs these tests. And this helps in precise subtyping of amyloid. With that, we go on to glomerular diseases, which can have many phases. Remember, I told you, the kidney has very limited patterns of glomerular injury, and this results in the situation where many patterns can be common to several diseases, and similarly one disease can have multiple patterns, and this is very challenging, and especially challenging in the interpretation of glomerular diseases. So glomerular diseases with many phases, there are two. One is IgA nephropathy, which is the commonest glomerular disease worldwide. And the second is lupus nephritis, which has a variable nature of glomerular involvement, may evolve over a period of time. It may wax and wane. It may transform over a period of time. So this is IgA nephropathy, and it is typically a mesangiopathic disease. One observes, you can see, look at this glomerulus, you see there's an increase in the mesangial matrix. There is an increase in the mesangial hypercellularity. Look, there are more than 3, 4 nuclei here. Here, there are even more. So there is an increase in the mesangial cellularity and increase in the mesangial matrix. There is not much endocapillary hypercellularity. Glomerular capillary walls are okay. They look normal. This patient had hematuria, there was proteinuria and hypertension. And on immunofluorescence, you find that there is staining, which is at least 2+ to 3+ for IgA. And apart from IgA staining, you may also see co-staining with C3 and IgG, sometimes with IgM. So this type of co-staining is known in cases of IgA nephropathy, but you must remember that the IgA staining will be at least one intensity more than the others. That is important. Second, you should not see staining for C1q. If C1q staining is present and you feel that your IgG and your IgA are almost equal in intensity, then you are probably not dealing with an IgA nephropathy, but rather it could be a lupus nephritis. So this is the typical appearance. It's mesangial deposition. It's a mesangiopathic disease. You do not really see deposition along the capillary walls with the IgA. If you do see it, if you do find it in some rare cases, you may find it. They are the ones which have a more severe type of disease. IgA nephropathy may be primary or it may be secondary. And secondary is well known in diseases like, say, the skin diseases or in liver diseases. It's a known well-known situation where you can get IgA nephropathy. Now let's look at the many phases of IgA nephropathy. And remember that I told you right in the beginning that it can look like minimal change disease. It can have, it's a mesangial proliferation. Look at the number of nuclei here, look at the mesangial matrix. It's almost like the branches of a tree. When you have a mesangiopathic disease, you have this kind of accentuation of the mesangium. The capillary walls are normal. There's no thickening of the glomerular basement membranes. Then you have this glomerulus, in which again there is hypercellularity, but it's segmental in nature, and probably there may even be necrotizing lesions over here. Here in this glomerulus, not only is it segmental, but it looks chronic, it looks sclerotic. So there is segmental sclerosis that has occurred over here. In this glomerulus, there's not only mesangial, but there's also endocapillary hypercellularity. Look, you can barely discern the capillary lumens. And so there is mesangial as well as endocapillary hypercellularity. And here you have a crescent. So this tells you the many phases. It can have a mesangial, it can be MCNS-like, it can have focal proliferation with necrotizing lesions, segmental sclerosis, it can have endocapillary proliferation, and it can also have crescents. So these are the many phases. And sometimes it may even coexist with others. The IgA deposition can damage the capillary basement membrane, and that can expose antigens in the basement membrane, and you can get anti-GBM nephritis. And here you have a case of IgA with anti-GBM nephritis, and look at this florid violent crescent that is present, which has even destroyed the Bowman's capsule. So when you see these type of crescents, you have to start suspecting an anti-GBM nephritis. And they are not like, the relatively docile looking crescent that you see in, say, IgA nephropathy, which is not complicated by anti-GBM nephritis. The ones which are crescents due to anti-GBM are like this, florid, in your face, and they very destructive crescents are a feature of anti-GBM nephritis. Another situation of IgA is that we must remember with IgA is that it can be an innocent bystander. You can just get staining for IgA in cases with minimal change. You can get with membranous, even with Anca-glomerulonephritis. There's a lot of IgA going around really. It's one of the commonest diseases, and there's a lot of IgA, and that somehow you can get IgA staining with even other glomerular diseases. When you are dealing with a biopsy with IgA, do not forget to use the scoring system, Oxford scoring system, which gives prognostic information. This is the MESC score. M stands for mesangial hypercellularity, E for endocapillary hypercellularity, S for segmental sclerosis, T for tubular atrophy, and C for presence of crescents. So these are scored on a scale of 1 to 3, and we have to include the score in our biopsy diagnosis. So this gives a fair degree of idea to the clinician as to what is the severity of the changes, how much are the chronic changes, are there crescents, are there changes that may respond to steroids? For example, endocapillary hypercellularity may be steroid responsive. Are there sclerosing lesions, segmental sclerosing lesions, because they can have a more severe proteinuria. So this has to be followed, the MEST scoring system. Now that brings us to lupus nephritis, which is very, very diverse disease. And it's a big topic by itself. All of these are topics by themselves. But just to give you an idea, you can have different types of immune complexes in lupus nephritis, because there are so many antigens to which antibodies are present in lupus nephritis. So antigens of intermediate size, small in amount, and high avidity will lodge in the mesangium, and you get a class 1 and class 2 mesangial lupus nephritis. Antigens of large size and large quantity will not be able to pass the fenestrations of the endothelial, glomerular endothelial layer, and they will then kind of settle down in the subendothelial space, and then you get class 3 and class 4 lupus nephritis. Antigens of small size, low avidity, in the sense low avidity means they are more cationic than anionic, and therefore they are not, they are not repelled by the GBM. And if there is an antigen excess, these can easily pass, the small size ones can pass through the endothelial, the fenestrated endothelial, and they can come and lodge in the subepithelial space, and you can get a class 5 type of membranous lupus nephritis. So here is lupus nephritis class 1 and 2. This is minimal mesangial, no changes on light microscopy or very minimal alterations on light microscopy, near normal appearance of the glomerulus, but on immunofluorescence, you will get staining. And the staining that you see in lupus nephritis is characteristically referred to as full house pattern, in which you get IgG, A, M, C3, and C1q. All of them are present. Note, C1q is present, and IgG staining, the intensity for IgG staining is higher than the intensity for all the others. So these are some features that you have to remember. This is mesangial lupus nephritis. Again, you can see that only the mesangial matrix is increased. There's mesangial hypercellularity. The capillary walls are normal. So on immunofluorescence, you will get only staining in the mesangium, and on electron microscopy, you will get only mesangial deposits. This is because it's a mesangiopathic disease. The proteinuria may not be so severe. The complement levels may not be very low, and there may not be much hematuria, and it is a less severe form of disease as compared to classes 3 and 4. Now, classes 3 and 4 are actually, they are part of the same spectrum. Class 3 involves less than 50% of the glomeruli. Class 4 involves more than 50% of the glomeruli. In class 3, which we call as focal involvement, because it involves less than 50%, the involvement may often be segmental in nature. So you can see here, there's segmental hypercellularity. I think there's also some necrotizing lesions, because you see this fluffy pink material, which could be fibrin, and these dots, blue dots here, which look like karyorrhexis because of fibrinoid, which can be seen. This is nuclear. These are damaged nuclear dust that is seen in a case of severe lupus nephritis. So this is class 3, and this is class 4, in which you can get massive subendothelial deposits, and these massive subendothelial deposits can give rise to severe thickening of the capillary walls, forming these wire loops. Sometimes the deposits are so massive that they are cut in cross section and they look like thrombi. They look like Hylian thrombi within the capillary lumen. So this is a class 4 lupus nephritis. These patients typically have nephrotic syndrome, they may have nephritic syndrome, they have very active urinaceous sediment, and they have low C3 levels. The low C3 levels occur because of deposition of the immune complexes in the glomerulus, activation of the complement cascade, and then with that activation of the complement cascade, the C3 gets depleted from the blood and it gets deposited in the glomerulus where the complement activation is going on. So actually, you can actually monitor the severity of the disease of the lupus nephritis by checking the urine periodically. So if the urine sediment becomes more active, more RBCs, more leukocytes, more RBC casts, then you can think that the disease is becoming more severe. And if the C3 levels, you follow the C3 level trends. Just one level is not enough. You have to follow the trends of C3 levels and see if they are going down. That means that the disease is active. If the C3 levels are normalizing, it's possibly that there is some remission of the lupus nephritis activity. So you don't have to keep doing a kidney biopsy to monitor the nature of the disease. And mind you, lupus nephritis is one of those diseases one of the diseases where you can have, over a period of time, multiple kidney biopsies being performed to know what is the nature of what exactly is happening at the tissue level. But you don't want to keep on doing that frequently, and therefore you have these stools, the urine sediment and low C3 levels. In fact, that's why they call the urine examination as a poor man's kidney biopsy, because it gives a lot of information from the amount of, uh, it gives a lot of information about the status of the glomeruli just by examining the urine sediment. On immunofluorescence, you find there's IgG dominance and full house pattern. And you find that the staining for IgG is like this, blotchy, coarse granular, and in the mesangium and along the capillary walls. And it's usually IgG dominant. And full house staining is present, C1q is present. On electron microscopy, you see these electron-dense deposits which are present in the mesangium. They are also present in the subendothelial location. This is the basement membrane. This is the subendothelial location. And sometimes these have an organized pattern giving rise to a fingerprint appearance. Class 5 nephrotics, class 5 lupus nephritis is membranous. You can see here there's hardly any hypercellularity in the mesangial areas. The cellularity is in the normal range, but what is abnormal is the capillary loops. They are thick and stiff, rigid, and we recognize this now as a pattern of membranous glomerulopathy. So they usually present with nephrotic syndrome, and it's interesting to note that the membranous glomerulopathy may precede the clinical SLE by several years or months. And class 6 is the next class, which is sclerosing lupus nephritis. There are some interesting facts about SLE. There can be variable glomerular involvement. That's a very characteristic biopsy finding in SLE because there's so many types of immune complexes. So the appearance in one glomerulus may differ from the appearance in the neighboring glomerulus. This is very characteristic. The second thing is class transformation. And, class transformations occur typically between 3 and 4. In fact, that's part of the same class. But you can have downgrading. So 4 can transform to 2. Or you can have upgrading, 2 can go to 4. 5 is usually the more stable of the lot. So how do you monitor this class transformation? Clinical monitoring, monitor the C3 levels, monitor the urine sediment, monitor the proteinuria. Severe cases of SLE may involve the vessels also and give rise to vascular endothelial damage, which is an SLE vasculopathy. It's important to note that SLE is not really a renal biopsy diagnosis. It's a diagnosis made by the ACR criteria, which are, criteria laid down by the American College of Rheumatology. You don't really make a biopsy. You don't depend on a biopsy to make a diagnosis of SLE. But at the same time, having said that, SLE is a disease which may evolve over a period of time. At a particular point in time, the patient may not have all the criteria, ACR criteria, to make a diagnosis of SLE, but you follow up the patient later and you find that the criteria are met over at a later period. So in that situation, you have to be aware of what are the various features which can be suspicious for SLE, and then you can tell the clinician that possibly that this patient may develop lupus at a later date. Now this is a very characteristic appearance of glomerulus. Almost has a MPGN like pattern. It has a nodular look, but there is no cellularity really. The nodules are, this is one nodule, here there is possibly another, but it varies in size. There's some increase in the mesangial matrix, and you can see that there's some capillary wall thickening. Could it be amyloid? No, because amyloid, this is the PA stain. Amyloid is never intensely pass positive. What else could it be? Look at this arteriole here, and you see this is the afferent arteriole, and it shows marked thickening of its wall. This probably is the efferent arteriole, which probably also is showing some thickening of this wall. So now we are suspecting that this could be a diabetic glomerulopathy. And on silver stain, this is the appearance. It often has a very lamellated appearance on the silver stain. and this is a diabetic glomerulopathy. Now, actually, you don't need to make a diagnosis, do a kidney biopsy to make a diagnosis of diabetic glomerulopathy. The clinician will know that the patient has an underlying diabetic glomerulopathy. If they have a retinopathy, they almost always have a diabetic glomerulopathy. And if they have proteinuria and a retinopathy, they know. So they would do a biopsy to rule out non-diabetic causes of the renal impairment. And there can be many non-diabetic causes. Diabetics can have infection-related glomerulonephritis, they can have other diseases. And also, you have to remember that the nodular KW lesions can mimic, from the pathology point, the nodular KW lesions can mimic amyloid, light chain disease, nodular MPGN, fibrillary and immunotactoid glomerulopathy. And this MIDD, monoclonal immunoglobulin disease, deposition disease, in fact, is a serious mimic of diabetic glomerulopathy. So immunofluorescence testing for kappa and lambda light chains is a must in every case of diabetic nephropathy in order to avoid missing the diagnosis. We'll just look at a couple of pictures of the crescents. And here, this is a text picture, but I like this illustration because it tells you how the crescent is formed. There's such severe damage to the glomerulocapillary wall that there are breaks in the basement membrane. Look at this break, and fibrin seeps out. And along with the fibrin seeping out, these cells, these parietal epithelial cells, they get irritated, they proliferate, monocytes leak out, and this combination of the fibrin, the parietal epithelial cells, and the monocytes, they form the crescent. And the crescent can be, it can be circumferential, it can involve the segment, it can involve variable number of the glomeruli, it can heal, you can get a fibrocellular crescent. This is a very bad crescent, which we have seen this picture earlier. This is an anti-GBM nephritis, and this is again a very bad crescent in anti-GBM nephritis, which has destroyed the Bowman's space, and eventually this spells the death of this glomerulus because the glomerular integrity is lost, and this glomerulus will get lost. So the crescentic glomerulonephritis can be classified based on immunofluorescence into immune complex type on the pattern of immunofluorescence. If it's a granular staining, it's an immune complex type. If there's very little staining, they are pauci-immune crescentic, and these may be Anca related. Sometimes these may be Anca negative pauci-immune crescentic glomerulonephritis. Anca related are either due to C Anca or P Anca, and again, that's a big topic by itself. Suffice it at this point to recognize how the crescents look, and that immunofluorescence is required in the classification of the crescentic glomerulonephritis. The severely destructive crescents with severe destruction of the glomerular capillary walls, as I emphasized earlier, are a feature of anti-GBM nephritis. And Anca-associated crescentic glomerulonephritis has crescents which vary in appearance. So some areas, some glomeruli may have fibrous, some may have cellular, some may have necrotizing lesions. And that's because Anca follow a relapsing and remitting course. And these crescents therefore can be of varying ages. And that is a very characteristic feature. When you see crescents of varying ages, that is, you should think in terms of an Anca glomerulonephritis. If you see necrotizing lesions of the tuft, that again should make you think in terms of a Anca glomerulonephritis. But having said that, there can be sclerosing lesions as well in Anca glomerulonephritis. Yet another thing that you need to remember about these crescents associated with Anca and anti-GBM, particularly Anca, is the crescents may be very destructive. They destroy the glomerulus, and they can give rise to a necrotizing, almost a granulomatous appearance of the glomerulus. So, and this is very well known in what is known as the granulomatous polyangiitis with vasculitis, formerly known as Wegener's granulomatosis. The granulomatous appearance of the glomerulus due to crescents is a well-known feature of granulomatous polyarteritis. So these are the various morphologic aspects that one needs to know about the crescents. And here is a case of anti-GBM nephritis with linear staining for IgG, very strong linear staining for IgG along the capillary walls. This is an infection-related glomerulonephritis. You can see that there is, it's a swollen, it's an enlarged glomerulus. There's increase in mesangial cells, and there is mesangial hypercellularity, and also there are these, can you appreciate these nuclei with segmented, cells with segmented nuclei? These are neutrophils, and these are the ones which are, this is an exudative form of crescentic, infection-related glomerulonephritis. It shows staining for IgG along the periphery, and it also shows staining for C3. And on electron microscopy, it shows the presence of humps. These humps don't really damage the basement membrane. They can resolve over a period of time. So in fact, infection-related glomerulonephritis is one of those situations where you really need not do a biopsy in order to make a diagnosis of the glomerular disease, because it has a characteristic clinical course, and then it starts resolving. The C3 levels which have gone down start normalizing, the urine picture starts improving, and biopsy is not required. But if the clinical course is atypical, that is when you have to do a biopsy in order to confirm whether it is an infection-related glomerulonephritis or whether it is something else. Coming to C3 glomerulopathy, it's a family which includes C3 glomerulonephritis and dense deposit disease. In order to make a diagnosis of dense deposit disease, you must do the electron microscopy. C3 glomerulonephritis or C3 in C3 glomerulonephritis, the staining for C3 by immunofluorescence should be at least 2 times more intense than the staining for others. That is, staining for more, at least 2 times more than staining for IgG or IgA or the others. The patterns it can have are MPGN, mesangial proliferation, endocapillary proliferation, and leukocytes. You should investigate the alternate complement pathways for workup of C3 glomerulopathy. There's a specific treatment directed towards the alternate pathway, and that's eculizumab. And you must do a paraffin immunofluorescence if you suspect a C3 glomerulopathy to look for masked IgG deposits. Sometimes, we send the bit for immunofluorescence is sent in the transport medium, and the staining for immunoglobulins can be less if you do cryostats, if you do immunofluorescence in cryostat sections of transport medium biopsies, the staining for the immunoglobulins may be less, and you may not pick it up, and you may think this is C3 glomerulopathy, but actually it is an immune complex glomerulonephritis because there's immunoglobulin deposits or masked. So you must do a paraffin IF in these cases. Sometimes monoclonal deposits are masked, and they may, you cannot pick them up unless you do a paraffin IF and unmask them. Paraffin IF is a very useful technique, and suppose, for example, you want to make a diagnosis of IgA nephropathy, which is an IF diagnosis. Really, EM doesn't have a role to play. But what if your IF bit has no glomeruli? Then you can use your paraffin section, the light microscopy, the block. You can use that, and you can subject it to pronase digestion, the enzyme pronase. It will break the cross linkages between the proteins. It will expose the proteins, and it will expose the antigens. And it's a very useful technique that is often used. So it can be used as a salvage technique. It can be also used to pick up masked deposits. So what are the therapy decisions? I will not go into the details, but you have to be aware of the implications of what diagnosis you make. So MCD, minimal change disease, treated with steroids, rituximab, and CNIs. FSGS If it's permeability factor related plaques, it may recur in grafts. If it's genetic counseling, family workup, treatment may not help much. If it's secondary membranous, treat the cause. If it's an MPGN pattern with dense deposit, then it's eculizumab and it may recur in grafts. MPGN pattern associated with plasma cell disorders, treat the monoclonal gammopathy. IgA, the treatment depends on the MEST-C findings. SLE depends on the class, activity versus chronicity. There are many others that I have not actually enumerated here. These are some important ones which have very specific treatment plans, and we should not miss these diagnoses. Any significant crescents, cryoglobulins, you have to do plasma exchange. And remember, when you're reading the biopsy, also the clinicians will factor in the extent of chronicity and activity in the tubulointerstitial compartment, not just in the glomerular compartment. And therefore, it is your duty to let them know how much active chronicity is there in the tubulointerstitial compartment, because that is irreversible. Chronic changes are irreversible. They will not respond to treatment. Then they will, kind of not be very aggressive in their treatment if there are severe chronic changes in the biopsy. And also the active changes in the interstitial compartment, like acute tubular injury, should be made known to the clinician, because acute tubular injury takes time to recover. It may take as much as 6 weeks to recover, and that may delay the improvement in the renal function in a given case, and that can be puzzling to the clinician unless it is mentioned in your report that there is a fair degree of acute tubular injury or severe acute tubular injury, etc. So what are the reporting recommendations? Don't just give the pattern of injury, give the diagnosis with adequate workup, with immunofluorescence, special stains, electron microscopy, genetic tests if necessary. Work it up as much as you can or refer it to another center. Give the pattern of injury. Mention the established score, class, and grade. Mention the associated findings in the tubulointerstitial compartment. Is there acute tubular injury? Are there active and chronic changes? Are there vascular changes? Mention the extent of chronicity, not just in the glomeruli. And in the glomeruli, you should look for chronicity in the form of segmental sclerosis, global sclerosis, but look for it in the tubulointerstitial compartment in the form of interstitial fibrosis and tubular atrophy. In the blood vessels, look for it in the form of sclerosis of the vessels. In fact, Sethi et al. Proposed the system of reporting by giving the primary diagnosis, pattern of injury, and they also propose a renal chronicity index, which is on a scale of 1 to 10 and which incorporates the chronic changes in the glomeruli, the tubulointerstitial compartment, and in the blood vessels. Having done that, we will just quickly run through a few images of tubulointerstitial and vascular disease. This is atheroembolic renal disease, which occurred in a patient who had undergone angioplasty a few weeks before the biopsy, and then he presented with acute renal injury. And you can see this vessel with the typical cholesterol clefts, and it's time. This is its characteristic appearance. Then we have here, this is, you almost think this is interstitial inflammation. There's some fibrin. Could this be a granuloma? But you cut deeper and you find that this is actually a vessel with severe fibrinoid necrosis in its wall. And this was a case of NPO ANCA positive microscopic polyangiitis. So when you see a lot of activity aggregated like this in the interstitium, almost granuloma-like, don't forget to cut deeper, go deeper, because that granuloma may actually be an underlying necrotic vessel or an underlying necrotic glomerulus, and which would help give you the diagnosis. This is a lupus vasculopathy with severe endothelial damage and severe, this kind of edematous looking endothelial swelling with luminal compromise. So lupus can affect not just the glomeruli, but in the vessels also. And in the vascular involvement may be in the form of multiple changes that not just this type of vasculopathy, but other types of changes have been also described. This is a case of typical diarrhea-associated HUS, And you can find that the glomerulus, this is what we call as mesangiolisis. You know, the glomerulus tuft, the glomerular tufts become loose and a little dilated, stuffed with RBCs. There's endothelial swelling, so the tuft, the glomerular tuft has a solid appearance. The capillary walls look thick. And, you know, sometimes this type of a pattern can be even mistaken for an MPGN-like pattern. So this was HUS. Look at this arteriole here with its intimal swelling. This is a case of acute pyelonephritis. You can see interstitial inflammation. And look at these casts. These are puscle casts within the renal tubules. And how do you distinguish acute pyelonephritis from, acute interstitial, tubular interstitial nephritis? Of course, you have the urine culture, etc. But if you see aggregates, localized aggregates of neutrophils in the renal biopsy, then that's when you have to start suspecting an infection. So neutrophils in the interstitium are not unusual. You can see them in tubular interstitial diseases, nephritis of various causes. You can see them in transplant rejection. But when they start aggregating, that's when you have to start suspecting an infective etiology. Now, this is a case of drug-induced interstitial nephritis where you find interstitial inflammation and you also see eosinophils. Sometimes you may even see a granuloma. This is a case of IgG4 related renal disease where you find this typical expansile storiform fibrosis in the interstitium with plasma cells, large number of plasma cells. Look at this expansile storiform fibrosis. Look at this cartwheel appearance. And this, of course, you confirm it by doing the IgG4 staining. You should see more than at least 10 IgG4 positive plasma cells in a given field. And you must do the IgG4 IgG ratio, which should be more than 40%. Remember that neutrophils are not seen in IgG4 related disease, and IgG4 related renal disease may be associated with a membranous glomerulonephritis. This is a 3-month post-transplant biopsy who had recurrence of primary hyperoxaluria. The patient, the diagnosis had been missed in the earlier biopsy and the earlier nephrectomy. And look at these crystals, polarizable crystals. Such patients, they require simultaneous liver and kidney transplant, not just kidney transplant. This is the native nephrectomy. They had done a nephrectomy earlier because the patient had stone disease. So this is the advanced, pyelonephritis. You can look at the sclerotic glomerular interstitial inflammation and these telltale crystals, which are polarization, calcium oxalate crystals. And this is one diagnosis that you must not miss. These are myeloma casts. They are dense, very thick, fractured, fragmented casts, and they elicit a macrophage response. Often they elicit a giant cell reaction. Look at the thick texture. They are very highly damaging casts. They damage the tubules. They cause severe interstitial inflammation. They present with acute renal failure. We must not miss the diagnosis because very often it's the kidney biopsy that is performed in a patient with acute renal failure. He doesn't come holding a placard saying that I am a case of myeloma. He comes with acute renal failure. He or she comes with acute renal failure. And you see these casts, telltale casts, and then you ask them to work up with the protein electrophoresis studies. So this is something that you must never miss. And you must look for it regardless of the age. We have seen this in young patients, 20, 25-year-old patients also. And this must be picked up. So as a rule, in any case of severe interstitial nephritis, I always look for casts. I try to see if they look like myeloma casts, and then, look for other etiologies. Of course, on immunofluorescence, this would be monotypic in nature. And this is an interesting kidney biopsy, which came to us as a referral case. You almost think this is an interstitial nephritis, We got only the HE slide. I don't have anything else to show you, but this almost looks like an interstitial nephritis, but you look closer and these cells are packing the blood vessels. This was a case of intravascular B-cell lymphoma. We referred, we referred it back to the lab that had sent it to us and asked them to do the CD20, and sure enough, this was an intravascular B-cell lymphoma. And before we end, this is how acute tubular injury looks. The tubules appear to have dilated lumens because of simplification and flattening of their lining. The term to be used is acute tubular injury and not acute tubular necrosis. And acute tubular necrosis is what we see with ischemia, infarction, and cortical necrosis, or because of ethylene glycol poisoning. So I would like to end by saying that when you're interpreting the kidney biopsy, know the common diseases, always integrate the histology with the clinical setting, do recognize and document critical features, especially the active and chronic features. Never avoid discussion with the nephrologist. Never ever sign out the biopsy without discussing it with the nephrologist. Not a single biopsy should go out without discussion. Evaluate further in the light of other investigations, not just immunofluorescence and electron microscopy, but other investigations, serologic investigations, or any others in the light of the clinical scenario. If there's a previous biopsy, pull it out and compare it with the biopsy findings in the current biopsy, or at least get information about what it showed if it was done at another institute. And be aware, say yes to the awareness of management implications, because your diagnosis is going to guide the clinicians in their decisions. And when in doubt, it's good to seek help when in doubt. And with that, I would thank you for your attention. Thank you very much.